Nuances of cataract surgery in corneal scar. Preoperative assessment includes monocular or binocular status of the patient, best corrected visual acuity of the affected eye, history of recent onset decrease in vision due to cataract, type and location of opacity, status of intraocular pressure, optic nerve, head and retina, visual potential as identified by refraction, PAM or electrophysiological tests. The need for additive procedures like sphincterotomy and/or optical iridectomy based on the pupillary size and the location of scar must be kept in mind. Differentiating the extent of blurry vision caused by the cornea versus the lens can be challenging. In this case, RGP over-refraction becomes essential. If an RGP over-refraction does not improve vision at all, the likely culprit is the lens. And if RGP over-refraction improves vision, the last thing we want to do is cataract surgery because the problem lies in the cornea. Intraoperative aids includes incision site depends on the location of the scar. Coaxial illumination improves visibility of capsule or hexis margins and posterior capsule status. Dispersive viscoelastic improves visibility. Cohesive viscoelastic stabilizes capsule or hexis. Pupil expanders like iris hooks, B-hex, Malugin ring may be needed. Trypan blue improves anterior capsule visibility safely. Transscleral or intravitreal illumination with a fiber optic light pipe can improve contrast and resolution over direct coaxial illumination through a cloudy lens or cornea. Preoperative biometry. Axial length and keratometry values did not freeze in IOL master. Hence, the keratometry values were taken from the pentacam and the axial length measurement from a scan. Here we present a video of a case of an adherent leukomatous scar, affecting half the visual axis, with posterior synechia and a complicated cataract following a healed fungal corneal ulcer. On examination, the best corrected visual acuity right eye is 6/9 and left eye is counting fingers. Slit lamp examination of the left eye showed an adherent leukomatous scar extending to the limbus, partially obscuring visual axis, while the rest of the cornea remains clear. After a quiescent period of 6 months, cataract surgery was planned. Preoperative evaluation of left eye showed grossly diminished cell count and pachymetry of 605 micron. The axial map shows central flattening with inferonasal extension corresponding to the scar. Using the SRKT formula with an A constant of 118.4, the calculated IOL power was 24.5 diopter, resulting in a predicted refractive outcome of -0.50 diopter. Aim is to provide optimal vision after phacoemulsification alone. 2 side ports were made. And using irrigation cannula as an aid and spatula used to separate posterior synechiae. After releasing the attachment to the posterior surface of the cornea using intraocular scissors, 3 iris hooks were applied. Capsule stained using trypan blue dye. The anterior capsule of lens was found to be calcified and thickened. Capsule or hexis was initiated from the area away from the scar, using a 26-gauge needle. Intraocular scissors and rhexis forceps were used to enlarge the margins of rhexis and complete quarters. Globe was rotated in between to improve the visibility of the rhexis margin. Rhexis margin was enlarged using rhexis forceps. Light pipe was used to check the continuity of rhexis. Dispersive and cohesive OVDs were used to coat the endothelium and applied to the corneal surface, enhancing visualization and magnification. A scleral tunnel was preferred and phacoemulsification was performed. Coaxial illumination of the microscope was used for epinucleus removal and cortical aspiration. Bimanual irrigation and aspiration was used for better control. Rhexis margin continuity checked using a light pipe. 3-piece intraocular lens was implanted in the bag. After visco wash, a watertight closure was achieved using 310-0 nylon sutures to close the side ports and the main incision port. Post-operatively, the best corrected visual acuity was 6/9 and N6 at 6 months follow-up from a preoperative vision of counting fingers. Another case of a 70-year-old male presented with gradual diminution of vision in his only seeing right eye. Slit lamp biomicroscopy revealed central macular opacity, with corneal facet, thinning, and dense nuclear sclerosis grade 3 to 4. Best corrected visual acuity was 6/36 and near vision was 36. Preoperative evaluation revealed grossly diminished endothelial cell count and pachymetry value of 507 microns. Cataract extraction alone was planned, avoiding more invasive procedures due to monocular status. Direct coaxial or paraxial illumination from the operating microscope causes scatter and reflection of light off the cornea, limiting the surgeon's view and reducing the depth of field. To overcome this compromised visibility, chandelier illumination is used for an enhanced view of the anterior capsule and the lens. It is hands-free and adjustable to intensity and direction. Whereas a light pipe is used transcorneally to assist with visualization, especially capsular hexes and cortex removal, requires an assistant to hold it. More cost-effective. 25-gauge trocar placed inferotemporally via uniplanar beveled incision for chandelier light insertion. Trypan blue staining of the capsule and use of cohesive as well as dispersive viscoelastic are the same as in the last case. Microscopic illumination is extinguished. Chandelier-assisted capsulorhexes, which provided enhanced visualization of the anterior capsule with improved contrast and resolution through a cloudy cornea. Clear corneal phacoemulsification continued, swapping between microscope and chandelier lights was performed. Transcorneal illumination using fiber optic light pipe minimizes aberrant reflection and scatter, resulting in improved visualization. It was placed on various locations on the cornea, usually at a 45-degree angle in the periphery, until the location of optimal illumination was determined. Chandelier illumination, along with a fiber optic light pipe, was used and provided enhanced visualization in certain scenarios. Epinucleus removal, irrigation and aspiration of cortical material done under chandelier illumination. Posterior capsule polishing and IOL implantation, with light pipe conformation for in-the-bag placement. Post-operatively, the best corrected visual acuity was 6/24 and an 18 at 6 months follow-up from a preoperative vision of 6/36. The post-operative outcome was gratifying, with no further surgical intervention needed. Ideal candidates for cataract surgery alone in presence of corneal scar partially involving visual axis are those with stable opacities and declining visual acuity attributed to cataract. The benefit is that it avoids risks associated with keratoplasty. The limitation is that the surgery is extremely exigent and protracted, though the final visual outcome may still be limited by corneal opacity. Various surgical options must be discussed, and counseling is crucial regarding the realistic expectations. Thank you.